This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
As I go into work every day as a GP, you're kind of thinking to yourself, where will I find AFib? And the fact is, you're far more likely to find it at your next CDM review than anywhere else.
Hello and welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today, I'll be reviewing the newly published Irish College of GPs General Practice Update on Atrial Fibrillation in General Practice with its author, Dr. Eamon O'Shea.
I'm Eamon O'Shea. I work as a GP in Galway City and I am the cardiovascular lead with the Irish College of GPs.
Eamon provides an overview of the new GPU, which was written in light of new international guidelines, including an evidence-based approach to management in primary care, chronic disease management strategies, and the importance of considering new-onset atrial fibrillation in the setting of other CDM reviews. Eamon also reflects on newer presentations and aspects of care, including the emerging patient use of rhythm-detecting wearables such as smartwatches, evidence around use of desk-side devices by clinicians such as the Cardia device, as well as the ongoing rollout of community integrated care hubs to enhance patient care. As usual, you'll find links to the new GPU, as well as other resources mentioned today in the show notes, along with chapter markers and a complete transcript of today's show. I began by asking Eamon why atrial fibrillation matters so much in primary care.
Well, I suppose any working GP takes an interest in something if it's something that happens commonly, if it's something that's important, and if it's something that you can make an impact on if you manage it correctly. And I suppose AFib certainly qualifies in all respects there. Prevalence is rising all the time. We've an ageing population and I think we're getting better at detecting it. So it's now estimated that there's a lifetime incidence of 1 in 3 for a 65-year-old European that they'll develop atrial fibrillation. And there was an interesting Danish study produced. They followed 3.5 million people for 20 years, so big enough study. And that showed us that patients with atrial fibrillation, they have a 40% lifetime risk of developing heart failure. They have a 20% lifetime risk of developing stroke. And they have a 10% lifetime risk of having a myocardial infarction or heart attack. So we can certainly say that it causes trouble. And we can say that it's common. And I think as a working GP in Ireland, we're well able to detect it. So I think it matters to me. I think it should matter to all of us as GPs.
And you mentioned a couple of the other chronic disease management or CDM conditions there within that framework of atrial fibrillation.
Yeah, when I'm thinking about atrial fibrillation, as I go into work every day as a GP, you're kind of thinking to yourself, where will I find AFib? And the fact is, you're far more likely to find it at your next CDM review than anywhere else because each of the 8 diseases that are part of our chronic disease management group of diseases, each of them, apart from asthma, is a risk factor for atrial fibrillation. So each day we carry out a CDM review and your nurse checks a pulse or you check a pulse. If we keep an eye out for atrial fibrillation, we're going to find it. And that's been shown in there's been 3 reports on the CDM project so far, and it has shown that we are finding atrial fibrillation in cases that hadn't been diagnosed heretofore. So it's an ongoing process, and we're going to keep detecting more of it. And by doing so, we're going to prevent strokes and heart attacks and heart failure in the future, which is exciting.
Very much so. And it is worth restating, you've already said it, but it's easy just to gloss over it, that all of the CDM diagnoses are related to, they're a risk factor for the development of atrial fibrillation with the exception of asthma. It's really quite a striking fact when you sit back and reflect upon it, as you said, that you're going to find the next AFib more than likely in your next CDM clinic. That's where they tend to hang out, as it were. In terms of presentation, you mentioned diagnosis, and your GPU divides patients into two categories: symptomatic and asymptomatic. I know a lot of listeners will have quite a degree of experience with AFib, but very quickly, what are our symptomatic symptoms? And then maybe delve a little bit deeper into the asymptomatic, if you wouldn't mind.
Yeah, so I suppose with your symptomatic patient, this is your person who comes into you complaining of classically palpitations. They might feel short of breath. They might have pain in their chest or a feeling of tightness. They feel unwell. So that person, once they start giving you that history, you are starting to think, I better check their pulse and get an ECG because they are likely to have atrial fibrillation or some other sort of arrhythmia. What's increasing in frequency, I think, for most working GPs because of the CDM reviews is that we're now finding a person coming into us feeling absolutely fine, no different to the way they were yesterday or at their last review. And incidentally, your nurse or yourself finds an irregular pulse, or you carry out an ECG, as is often happening during CDM reviews now, and find incidentally that this person has atrial fibrillation. And you might ask them, well, John, do you feel any different? We've noticed this in your heart. And they will tell you straight up they don't feel a bit different. And maybe delving deeper, they might work out that they've been feeling a bit more tired or whatever. But there isn't any specific classic symptoms of the palpitations and the shortness of breath and that. So I think most GPs are coming across more and more of these cases as we go along. And I suppose the third way increasing in the modern world is detection by wearable devices. So more and more people are wearing kind of smartwatches and smart monitors, and they have the capability now to tell you that you may have atrial fibrillation or you may have an irregularity of your heart rhythm. And I suppose the point to make about that is that should be confirmed by what we'd call a proper ECG, either a single lead or multiple lead ECG, to be sure that it is atrial fibrillation rather than just a suspicion of that. So those are the three kind of common ways that I think most of us as GPs will come across. Your classic symptomatic patient, your asymptomatic one, incidental finding, and then maybe somebody with a wearable device diagnosis.
And could I just ask you about the wearable device? Because I guess it is going to be something that we're going to see more commonly as the 20 and 30 somethings with the wearables. They're not likely to throw the wearable in the bin when they hit their 50s and 60s. I think that's the new normal now, really. You may say, okay, well, I want to confirm this with my formal ECG, which may be normal, but where would you say, well, I might refer for a Holter because it could be paroxysmal, or how would you satisfy yourself that this is just an issue with the device?
Yeah, and interesting you mentioned Holters, because I suppose that was traditionally the way. If somebody presented with symptoms, or now in the new world a kind of a smartwatch that says there may be AFib here, but you don't find it at that moment in time that you're consulting with them, then there's still the possibility that they're going into paroxysmal AFib, in and out, and you might be just catching them at the moment when they don't have it. So the traditional way was you put a Holter monitor on, and that was put on for 24 hours or maybe 3 days or even 7 days if you were very lucky. But of course you still mightn't find it because maybe they won't have that episode of AFib when they're on it. And increasingly, the use of devices, people will be probably aware of the trade name, the Cardia device, where somebody has a device that they can carry around with them, and if they get the symptoms or if they feel they might be getting an episode, they can record themselves. So the value of it, I suppose, is that it's prompted by the person who can carry it with them at all times and catch the rhythm disorder. And recently enough, NICE came out with a health technology assessment. So that's like a guideline they do of devices and various things. And they actually worked out that using a Cardia device to diagnose potentially paroxysmal AFib was from a health economy point of view, probably made more sense than using Holter monitors. So probably in the long run, Holter monitors will become less used for those kind of suspected paroxysmal atrial fibrillation investigations.
And one of the points you make in the GPU is around the wearables. And while Cardia, as you said, has been kind of given the imprimatur of NICE in terms as a credible diagnostic tool, including single lead, as you said, which is quite interesting, the evidence around the wearable devices is not as robust in terms of specificity, isn't that it?
Yeah, so they're good at telling you might have it, but I suppose when they looked into it, there was a recent Apple study, and there's been a couple of others with other devices. But I think roughly about a third of the ones that the study had found may have it went on to have atrial fibrillation when they did more long patch testing. So it's a good kind of. It's something to highlight that you might have it, but I suppose we'd all might be concerned with, as GPs, as kind of tons of people coming into us all the time saying, I might have AFib, I want to be investigated, and you'd wonder whether that's an appropriate use of resources. So in that personal situation, and this obviously means a cost to the patient, but if they were willing to pay the cost of buying a cardio device, that might be a way of checking this out. And maybe in time to come, it might be an appropriate use of hospital departments instead of doing Holter monitors, that they could have a set number of cardio devices to hand out and let people catch the rhythm disorder if it exists, rather than using Holter monitors. But yeah, and I think I've also mentioned in the GPU, we're probably a little bit far away yet from screening for atrial fibrillation. So the whole population having a wearable device that tells us we might have AFib, I think we're a bit away from that just yet.
You're getting me to put my, I suppose, services hat on here, and maybe I'm derailing the conversation ever so slightly, but you mentioned maybe cardiology departments offering cardias, but I guess the cost has come down, and this is not an ad for cardia devices, but there's nothing to stop a practice, I suppose, from offering such a service as well, to have a few of them in the drawer and to be able to give them out to a patient, show them what the app is, and say, come back to me in a week and we'll follow it up.
Yeah, I mean, I think definitely these kind of devices, lots of GPs are using them now. There is, that for catching the likes of atrial fibrillation, they're so handy. Like, obviously a 12-lead ECG gives you so much more information in terms of possible ischemia or ventricular hypertrophy. But for actually just catching atrial fibrillation, just a single lead ECG is just as good, to be honest, just as valid. And the latest European Society guidelines said that a single lead or multiple lead ECG is appropriate. What they won't kind of stand over is, diagnosing atrial fibrillation on the basis of the wearable itself, or a smartwatch telling you of atrial fibrillation. You can't diagnose it that way yet.
And that stands to reason, Eamon, because when I go to the gym, my own smart device tells me my heart rate is about 95 when it feels like it's 180, and I get into arguments, but that's probably that's more personal than the device's fault. Okay, let's say we have our patient now. They have AFib. And now we're going to move on to the next step, which is, what do I do with my patient? Could you start with telling me maybe when did these people need to go to hospital now?
Yeah. So, and again, I'm conscious most GPs have a very good feel for this. This is something that your average GP, has a very good idea about. Somebody who's very unwell, who's hemodynamically unstable. So if their blood pressure is low, the guideline is saying below 90/60. I think some of us would probably get worried if it gets even a little bit higher than that. If their heart rate is above 120, if you suspect that they've associated heart failure with it, so the signs of pulmonary edema, peripheral edema. If, let's say, they've pain associated, so you're worried they might have a PE in addition to the new onset of AFib. If they have symptoms suggestive of an infection, along with new onset of AFib. Obviously, a younger person, particularly anybody under 16, and I suppose a high level of symptoms. So if they've really seem to be quite symptomatic with it, that's the kind of person that I think all of us would kind of think, I better get somebody to see them in the hospital today. So that's like an ED or an AMU, depending on what service is available to you in your locality. That's that kind of person.
And could I ask, because it's a burning question of mine, you mentioned the patient with the infection, with the associated AFib. When the infection is cleared, are they left with the AFib diagnosis?
Yeah, well, they technically are. So you've got somebody who might have just one provoked episode of atrial fibrillation, but chances are they've got other things going on that mean that AFib is likely to come back. And that's somebody certainly that should be followed up to see, have they got paroxysmal AFib? So are they going in and out? And so I don't think you could forget about somebody who just had one single provoked episode of atrial fibrillation and decide they're fine, they'll be grand now once that infection is clear. I think that's somebody who needs a bit of follow-up in terms of probably what we talked about, following them up with some sort of monitoring device to see are there other episodes happening.
And on the other hand, would it be reasonable or unreasonable to treat based on that index presentation? Longer term with a NOAC, for example.
Yeah. I think if the issue, I guess, is that there was a feeling previously that a person with paroxysmal atrial fibrillation was at less risk than a person with permanent atrial fibrillation having a stroke, and that's no longer the case. So you're still at significant risk of having a stroke if you have paroxysmal atrial fibrillation. So the consideration of the DOAC is just as strong.
Okay, and that idea around whether to intervene brings me neatly onto the idea of the CHADS-VASc. I am going to just mention briefly that I suppose when I was in training, has bled was still the other side of the seesaw, but really it's the CHADS-VASc now, isn't it? And the other thing is that the guidelines have changed in terms of removing gender.
Yeah, so we've two major, I suppose, new things to do with the latest iteration of the European Society of Cardiology guidelines is one, that they've taken gender out of the equation. So it used to be the CHADS-VASc score and now it's CHADS-VA. I suppose the other one is that they're, interestingly, because like you, I'd have been toiling with Orbit and with Has Bled and various other scores for kind of seeing, is this person a high risk bleeder or at risk of high risk of bleeding. And they're recommending now that we don't do such scores. We should consider the anticoagulation and be mindful of factors that might increase the risk of bleeding. So uncontrolled hypertension, heavy alcohol intake, if they're being co-prescribed medication that might increase their bleeding risk, like antiplatelet agents or non-steroidal anti-inflammatories or steroids themselves. So that we shouldn't be ruling people out of anticoagulation with a risk score.
And then the other big thing, what's nice, I suppose you could say about our conversation, is we haven't had to mention warfarin once yet, because things have changed so much with the DOACs. And I have my patient in front of me now, and I'm happy that they do meet the criteria with the CHADS-VA to commence something. But then a little voice in the back of my head says, hang on a minute, could this be valvular? Or, is there a contraindication to starting? What do you have to say to that concern?
So this is a dilemma I think a lot of GPs have. I'm old enough to be used to the fact that if I diagnosed atrial fibrillation today, I probably need them to be seen in hospital today. They need to be seen to get sorted. That's probably what we're a lot of us are quite used to. And I suppose things are changing a little bit. We've to consider that, your elderly person who's presented to you who feels fine and hasn't a bother on them, and you've just found AFib, you got to wonder, is it a good idea to send them into a place where they'll have to lie on a trolley for hours and hours to be seen and sorted? So the fact of the matter, I guess, is that the vast majority of people that you see, particularly that asymptomatic person that you found on a CDM review, if you have a listen to their heart and they don't have a new murmur, if you're going to know as their GP whether they've had mechanical heart valves, and they're likely to be on warfarin already if they have, then really the risk-benefit ratio is more in favour of giving them a DOAC and let them see a cardiologist if you wish them to see one as an outpatient, either in your integrated care hub or in outpatients, rather than packing them off to hospital to wait to be seen there, with the associated risks of that, of picking up a new infection or something else from hanging around the hospital too long. So I suppose when I was writing the GPU, I was kind of thinking of those questions. Who needs to go to hospital today? If they don't, what can I do for them? And the fact of the matter is that if you're happy enough that they're well enough to stay out of hospital and don't need to go today, you can consider treating, including the anticoagulation, without them going to hospital to make that decision.
Yeah, that's very reassuring. And I suppose you could say it makes sense, doesn't it? But the important part there, as you said, is to examine.
Yeah. And it I suppose brings us on to the next bit, John, is that people might often feel, does this patient need to have an echocardiogram before I can, give them a DOAC safely? And again, it's highly unlikely that this person is going to have a condition that you can't find clinically yourself that would stop them safely getting a DOAC off you today while they wait to be seen. That's the bottom line. The incidence of somebody with severe mitral stenosis that you're not aware of, or mechanical heart valves that you're not aware of, is exceedingly slim. And when you think of the benefit of stroke reduction that you're going to provide by giving them that DOAC, the balance is majorly in favour of giving them the medication, in my view.
Okay, that's very helpful. Thank you. When I think then about, say, okay, I'm going to give my DOAC, and then we're going to have that thought process, at least around the potential role for cardiology, you then go on in the GPU to consider the options in terms of rate control and rhythm control. And before we delve too deeply into it, on the rate control side, which is what I would be more accustomed to say, commencing a beta blocker. If somebody has an AFib, but they're sitting around a kind of a 70 to 80, mid-80s irregular rhythm, would you still recommend commencing a very low dose of something like a bisoprolol, just in case they were to run fast outside of your clinic setting?
Yeah, the latest iteration of the European guidelines are actually fairly, and they even use the word lenient in terms of the control of heart rate in atrial fibrillation. So they're happy enough with a resting heart rate of less than 110. So if you were starting somebody on a beta blocker and you were reviewing them and their resting heart rate was under 110, they're happy enough with that, because they've looked at that and they've compared people with that more lenient control with people that have stricter control of kind of getting it down to more normal levels, what we'd be used to calling normal levels, the 60s, 70s. And they found the ones with the lenient control did just as well. So the person who's sitting in front of you and has what we call a normal rate of 60 or 70, you may not actually need to start a beta blocker, but obviously you'd be reviewing them again to see, how do things change over time.
Okay, that's useful. And is there anything else that you wanted to mention you've given me a very clear overview of an approach to the rate. Is there anything else you want to mention before I move on to rhythm?
No, I suppose there are a couple of people that you'll come across that may not be good candidates for rate control with a beta blocker. So if we're used to using the cardioselective beta blockers like bisoprolol, I suppose most of the time, but still there might be some people where it's not appropriate to use a beta blocker. In that case, there is the option, and it's mentioned in the guideline, of using rate limiting calcium channel blockers. Like verapamil and diltiazem. Lots of GPs may not be confident in doing that, and I think if you're not, you're safer to get the advice of your cardiologist. And certainly people who are not controlled with a beta blocker in terms of rate control is somebody that you should be getting the advice of your cardiologist for.
Although you do, just as of note to listeners, there are some very useful appendices to the new GPU in terms of the kind of medications that are used in AFib, potential issues from them, doses and monitoring. So it's all there at a glance in the guideline, which is really useful for all practitioners.
And our chat today we wouldn't be able to do justice to in terms of the detail. And that's the kind of thing I suppose as a GP you want as a reference more than anything else. But there's tables on that I've got from both American and European guidelines on, the little nuts and bolts of maybe things to look out for and therapeutic tips on uses of the drugs that are commonly used in rate control and rhythm control and obviously the anticoagulants. So that it's all there and reasonably good resource to have on your desktop.
Okay, so going back to the therapeutic tips on that GPU, Eamon, if you could convey one take-home message or one pearl to GPs on the therapeutic side, what would that be?
I think it would be related to our CDM reviews. So as people know who are working as GPs, we do bloods on annual visits for our CDMs, and then there are interim visits for our patients. And some of those visits, those interim visits, like for asthma or COPD, don't need bloods done. But the two that do are atrial fibrillation and diabetes. And just to tease out for a moment, why is it important that we do a renal function test on an atrial fibrillation patient every 6 months? And the reason is that the DOACs, as somebody gets older, may need to have their dose reduced. So it's important to check their creatinine and their EGFR because and the detailed advice is in the GPU. But if somebody, for example, who was on apixaban was over 80 and had a creatinine that was rising, that might be a situation where we need to reduce their dose to half of the original dose. So this group of people are generally older. And they will be getting to that stage where the dose that once was the case for them early on in their diagnosis is no longer. So it is important to keep a close eye on renal function, particularly related to the DOACs.
And I guess one of the take-homes from one of those CDM reviews that was published by the HSE was around the pickup rate of CKD amongst CDM patients. And it's a very useful reminder of the value of the U&E, not just for things like DOACs, but more broadly for therapeutics in chronic disease management patients, because just like AFib should be thought about in the CDM context, the renal function should also be thought along similar lines.
Absolutely, and it's possibly a subject for another podcast, but I think that kind of management of CKD in general practice, it's such a common problem, and I try to explain to patients that actually finding it. So you've got your filter, which is the kidneys, you've got your pump, which is the heart, and you've got your pipes that are transmitting the blood around. And when we find a problem with your filter, it's not necessarily that the filter will be the big problem later on in life. It's that it'll cause a problem with your pump. So when you think about it, most of our patients with CKD unfortunately won't live long enough to need dialysis. They'll actually die of a cardiovascular event before that happens. So really important.
From my side, Eamon, I love collecting little stories that I can share with patients that make it easier for them to understand their conditions. And common household appliances, plumbing, goods, I find really useful. And that's one I'm definitely going to add to my repertoire. So thanks a million for that. Okay. I've started my patient on my DOAC. I may have started them on a beta blocker. I may have started them on a verapamil or a diltiazem if I have a comfort level to do so and it's appropriate to do so. And I've sent them away and I'm satisfied with my initial management. Can you tell me a little bit now about review? And I guess we're getting into the area of chronic disease management as part of this.
Yeah, so I hope you've registered him or her on your CDM, most importantly. So you're going to carry out a registration visit either on this visit, or if time is of the essence, you might have to do it at a later date. But it's really important to do that, because registering somebody for CDM will mean that you'll now hopefully be tying them into a follow-up plan, which means they'll be seen every 6 months and do what we're all doing at CDM reviews, which is, symptom reviews, measurements of simple things like weight and height and blood pressure, appropriate blood tests. And I suppose the big thing to talk about here from my point of view is a big change in the kind of the tenor of the guidelines of late is to consider the issue of comorbidity. And atrial fibrillation doesn't stand alone usually. There's often stuff in the background, and somebody who's carrying extra weight, somebody who drinks more than they should, somebody who's got hypertension that isn't well controlled, somebody who's living with diabetes who isn't well controlled. These are all situations that will make it more likely that their atrial fibrillation will cause them more trouble. And so at each review, we should be thinking about those comorbidities. So we talked at the start of this about saying, where am I going to find AFib? It's likely in a CDM review. And CDM reviews are such, I suppose, if you want to put it this way, a rich source of pathology in one sense, in that there's a lot not happening. And if we keep our antennae open for other situations or other conditions that might be causing problems, it will not only help manage those conditions, but in terms of AFib, it'll improve their control of AFib.
And you mentioned a number of comorbidities there that are already captured in CDM and in reviews. And I suppose the use of CDM, or one of its many uses, is that it refocuses the mind on the various risk factors that this patient now has, given they already have one significant chronic illness. One that jumped out at me from the GPU was obstructive sleep apnea.
Yeah, it's something to consider. I think it's one of those things. I remember the BMJ had a series called Easily Missed Diagnoses, and OSA was one of those. And I think it's true. It can sometimes be kind of hiding in the long grass. In terms of atrial fibrillation, I suppose it's more common in patients with AFib. There isn't really evidence yet for screening for OSA in a person with AFib, but particularly those that you're considering a rhythm control. So people who are, and we haven't talked about ablations and that kind of thing, but if people were getting ablation done, it probably makes sense for the cardiologist doing it to screen them for OSA, because if they have sleep apnea, they tend to not do so well after ablations. They tend to recur. But yeah, I think, look at obstructive sleep apnea is certainly something that we should be considering at lots of CDM reviews. The other thing I suppose to point out, just while I'm thinking about CDMs, that there's such a time when improving a few things can actually have an impact on lots of different conditions. So if we talk about somebody's weight and manage to get it down, that will help their atrial fibrillation. But if they do have diabetes, it's likely to help that or prevent onset of it. Alcohol intake, reducing that will help lots of conditions, but particularly atrial fibrillation. And the other big thing, I suppose, with people with atrial fibrillation, sometimes have the notion that physical activity is not to be done, or is something that will bring it on or make it worse, or maybe they should kind of do less because it'll make them feel unwell. When actually it's been shown that regular physical exercise reduces symptoms and reduces the burden of AFib. So if we're seeing somebody with AFib at a CDM review, we should be encouraging them to stay as active as possible, that it's good for it rather than bad for it.
And again, wheeling back around then to, you just briefly mentioned about the ablation piece, and the international guidelines have kind of leaned into that a little more. And I know you're not going to ablate anybody in primary care, but it does, again, bring in this idea of the combined care potentially with cardiology, and the value of the rollout of the integrated hubs in terms of getting input from our colleagues maybe in a more expeditious manner.
Yeah. So I suppose that bring, if we're thinking about, our case that came in with the symptoms, the kind of younger person who feels very unwell, that's the person we're sending off to ED, and they'll often be considered for cardioversion and possibly ablation. But you might think to yourself, what about this older person that I've happened upon? Should they get consideration for rhythm control? And the answer is they should. But there has to be context. So not everybody. So if they've had atrial fibrillation for less than a year, if it's paroxysmal or persistent, if they're under the age of 70, if they've got a low frailty index, so they're a reasonably good fit under 70-year-old, if they've got associated heart failure with their atrial fibrillation, or if they got a poor response to rate control, so they're not doing as well with your attempts to bring their rate down. These are all people that have been shown to do well with ablation. And hospitalizations and death due to cardiovascular events has been reduced with the latest trials that have come out in terms of ablation. So I think ablation is something that will be more widespread as the time goes on. Obviously, access to it is a big issue, particularly in Ireland at the moment. We just don't have enough people available to carry out the service. But the evidence seems to be moving more in favour of trying to get these people's rhythm controlled, as opposed to just letting them live with their AFib.
Before we wrap up, I should mention that the college, to its credit, has a suite of resources, not just around atrial fibrillation, but around cardiovascular disease more broadly. Are there any key resources from college or elsewhere that you'd like to bring to listeners' attention?
Yeah, so I think in general, the suite of GP updates that are available on the ICGP website are such a rich source of information, not just for cardiovascular disease, but for lots of other things, and really, really useful. And they're designed for GPs, by GPs, and they are designed for the busy working GP who doesn't want to spend time reading a 100-page guideline. They're distilled, and they're distilled for you, knowing that you're a GP working in an Irish context. So that's the important thing. So they are there. Some of them done by my predecessor, Joe Gallagher, some excellent material from a cardiovascular point of view. And I'll be updating one on heart failure in the next 6 months also. In terms of other resources for atrial fibrillation, I guess the European Society of Cardiology have issued guidelines in this past year, and they formed the basis of my GPU. They're an excellent source. There's also a recent American guideline, and there's a list of references at the back of the GPU for people that want to dive deep into this in more detail.
And what I might do is just pick a few of those out with you, Eamon, away from this forum, and just put those into the show notes for listeners to be able to access from their device as well. I feel we've provided a real whistle-stop tour of the new GPU, and congratulations again. As you did say, this does not replace the GPU, and it's really a real useful guideline to have available on your desktop in practice. I found it really useful just to update my own take on atrial fibrillation and some key changes that I'm going to make in managing my own cohort of patients. So thanks again for your time again today, Eamon, and best of luck with the new release.
Thanks a million, John. My pleasure.
Thanks again to Dr. Eamon O'Shea for participating in today's show. And don't forget to check the show notes for chapter markers, links to resources, and a full transcript of today's episode. If you have any comments or feedback on today's show, we'd love to hear from you. Please email us at podcast@icgp.ie. That's it for today. Many thanks for listening, and until next time, take care.